thank Dr. Giridhar and the organizers for giving me an opportunity to be a part of this IC. As Dr. Giridhar said, it's a very important topic, so I'll be giving a very long lecture in a very brief time. So, as my talk will be on, I'll be dividing it to the definition, comparison of various drugs, the role of laser, whether it is macular laser or peripheral laser, and PPV. And many of you may be aware that there is no clear-cut answer for all of these, but we'll see how we can improve on our understanding at this point of time. So, what is the meaning of recalcitrant DME? Now, there's a differentiation between recurrent DME or edema and recalcitrant. Recurrence we all expect, and if there is initial response and then the drug effect goes away, the edema comes back, you can always treat again, and patients can still understand what's going on. That the effect of the drug, when it goes away, there is recurrence of edema. But what about recalcitrant? So, in terms of AMD, we have better definitions, but as far as the Indian practitioners, retina specialists are concerned, based on our own surveys, we usually switch after 2 or 3 anti-VEGF injections initially. There are many publications on DME management, including the Indian guidelines, which has been accepted recently in IJO, and Dr. Giridhar and Dr. Jay are also part of that guidelines. There has been no clear-cut definition of recalcitrant DME because it's not an easy answer. And also the other guidelines, there are no clear-cut definitions. I am not going into the details of any of the trials listed here, but all I want to say, there have been many trials looking at specific drugs, particularly as monotherapy or as comparative trial with either laser therapy or sham injection. But there has been no large randomized trial which is purely focusing on recalcitrant DME. If we see the various trials, including the very important DRCR trial of protocol I and also the Restore trial, they usually advocate treatment initiation at 2030 or worse. The other 2020 DME already has been discussed earlier by Dr. Mahesh, but usually if the vision is less than 2030, we usually go for anti-VEGF injection. And invariably all guidelines, some of them recommend 6 injections and then decide, but invariably most of the guidelines recommend that you should give 3 monthly injections of anti-VEGF and then decide what is the next course of treatment, whether it is PRN or the same treatment or you want to do something else. So, by this it is implied that recalcitrant DME may be defined as no reduction in edema and OCT after 3 injections. Looking at various drugs, as I mentioned, there is no specific trial, prospective trial on recalcitrant DME. There are reports of that, including from our India by Dr. Pukhraj Rishi from Shankar Netralaya, a very small series of just 3 eyes. But we have comparative trials in naive patients, and the most important them is Protocol T, which was published last year. I am not going to again go into the details because it is not relevant for recalcitrant DME as such. But if you look at the methodology in which they gave the first dose and then immediately after that they have retreatment criteria for re-injections. And if you look at the overall results, there was not a significant difference in terms of the visual acuity overall. But if you look at the patients who had less vision at baseline, less than 20/50 at baseline, they tend to gain better. Whether it is each drug individually, that is, you look at Eylea, Avastin, or even Lucentis, individually they did better. But overall, if you see, there was slightly higher difference in terms of the Eylea group which they had. But again, the problem here was the Lucentis was 0.3 milligram because it's a North American study, whereas in most of the world, the DME management is again with 0.5 milligram of Lucentis, so which again raises questions about the Lucentis results in this trial. Now, I will be taking through some of the cases where we have had very challenging situations in managing DME patients in spite of repeated injections and using different kinds of injections. We were having difficult situation. So we have a patient here who had presented in 2010 with vision of 2050. The left eye had just been operated for cataract and had been lasered for diabetic macular edema, and this right eye had cataract, mainly posterior subcapsular cataract. Patient underwent phacoemulsification, and the first post-op day he got 20/20 vision. Excellent outcome. But with DME, you can never predict when it's going to happen, especially after cataract surgery. Not on the first day, but in a month or two, usually they start developing diabetic macular edema. And this is what happened in this patient. Patient started dropping vision. If you see the OCT shows macular edema and subretinal fluid. And at that time, we gave 3 injections of Avastin. And then in spite of that, the patient kept on having macular edema with worsening of vision. So at this point of time, the vision has dropped from 2020 on the first post-op day. Then he had macular edema. We gave 3 injections. In spite of 3 injections, it is worsening, and 2160 was the vision. So at this point of time, we gave triamcinolone acetonide, which is what the natural practice pattern, the treatment practice pattern used to be at that time in 2011. So after intravitreal triamcinolone, the patient's edema improved, the vision improved from 2160 to 2040. But then again it started worsening, and the vision dropped to 2200. So first day after cataract surgery it was 2020. Then look at the turbulent course over the next 1 year. 3 Avastins, 1 IVTA, and then again it has come down to 21. We again gave one last try of Avastin just to see if it comes back, but the vision did not improve, 2200. So at this point of time, see, there is no VMT or ERM in this case, but we decided that enough is enough. So many injections, no improvement, only worsening. So we did vitrectomy, ILM peeling in this case, and fluid gas exchange in early 2012. And at 1 month post-op, the vision had improved. I mean, even though the edema is still there, especially on one side and also in the fovea, from 2200, the vision has improved to 2064. And over the course of time, and whenever you do vitrectomy in such cases in diabetic macular edema, as not a first resort, as a last resort, usually you have to explain to the patient it's going to be a long time before we see a final closure of the macular edema. It may or may not even happen. The next case which I am going to show is going to show that the edema keeps coming back even after vitrectomy. But this patient improved slowly over 4 to 6 months, and then his vision improved to 2030, and at 6 years follow-up after 2010 when we started this, vision has been maintained, and we have not added any further injections or laser to this patient. But let me tell you, this patient was lucky. So because let's see the next patient. This patient came to us in 2013 with a long history of diabetes, HbA1c of around 9, and patient presented with diabetic macular edema. And 2040 vision, we gave 3 Avastins, 1 IVTA over the next 9 to 12 months, and you see that the vision from 2025 has come down 2040, but there is a small vitreomacular traction which is now developing. Now you have to start talking to the patient about surgery, because VMT usually in diabetic macular edema surgery is indicated. And we said that yes, you are likely to have surgery, but patient was tired of so many injections and he wanted assurance that, oh doctor, after surgery will I be okay after that, so no more injections after that. I was like, not extremely confident, but I was optimistic. In my heart, I wanted to tell, yeah, I think this because of VMT. Let us assume it's because of VMT. We do the surgery. I think you'll be fine, because the previous patient without VMT did 20/20. So let us see. I think I'm very optimistic, and then let's see what happens. Obviously, after 2 months when he came, vision had dropped, and we said, okay, it's time to have surgery, vitrectomy, membrane peeling. And after 1 month, vision had dropped from 2040 to 2160, and patient has come back with his family. He was used to come alone earlier. Now he has come with 3 people just to talk to me. Doctor, what's going on? You are now in a difficult situation. So now you are seeing subretinal fluid, massive edema. What do you do? Now again you say more injections and more injections. The question will be, why did you do the surgery then if you had to do the injections? So now let's see, again as I said, the previous case, you have to tell the patient it will take some time before the edema settles down. And I told this patient also earlier, let's wait, it's just 1 or 2 months now. Let's wait for another 2-3 months. I think it should improve. And yes, the edema, there is central foveal thinning, but parafoveal edema has not improved, vision has not improved. vision is still the same after almost 6 months, and the patient is really frustrated. So what I told the patient was, now you see the edema has slightly reduced, as you can see. Now it's, I think, cataract which is causing the problem. Now let us do cataract surgery and give IVTA, and this is what we did. So patient improved to 20/60 now. Good. 20/20 to 200, 20/60 are improving, but not what he was earlier. So after the surgery we have lost vision, but now at least we are settling down. Okay, there's something. But then when we are about to settle down, then again he starts recurring. He goes back 2200. Now we gave IVTA during cataract surgery in a vitrectomized eye, and he is now complaining of floaters. So he was complaining that it's worse to have floaters rather than poor vision. So now we were discussing seriously about doing a vitreous lavage just for removing the IVTA, because he is a bank manager and he says life is really frustrating for me. So because he had received IVT earlier, we had discussed Ozurdex. Now by this time Ozurdex was available, but he said that because he has received IVT earlier, showed a good response, let us give IVTS. So now my take is that not try IVT in a vitrectomized eye, and also because in a vitrectomized eye the pharmacokinetics of drugs is totally different, whereas in Ozurdex because it's an implant, the drug release is the same whether it is vitrectomized or non-vitrectomized eye. It also avoids floaters. But then again, after 2 Ozurdex, we are coming back to the same problem, 2200. Just last month he came again with 2200, massive edema. I said, let's do an FA. We will do a peripheral retinal evaluation for ischemia. We did mild scatter photocoagulation. My fellows came back, doctor, why are you advising photocoagulation? Does he have envy? I said, no, it's because of the macular edema. Sent him for another opinion for my colleague. He also agreed, let's do laser. We don't have any other option. But again, he has come back, there is no improvement. There is no improvement. What I am trying to say is, yes, there are publications on targeted retinal photocoagulation. Some patient may improve, but it's not necessary that they will improve. So it's due for another Ozurdex at this point of time. We have the Champlain study, which was Ozurdex implantation in vitrectomized eyes. I mean, this is just to support our line of management that Ozurdex can be given with good results in terms of improvement, but you always worry about recurrence. So diabetic vitrectomy may not prevent recurrence, although it can have improvement.
You like to speed up.
I have just one more slide after this. So in terms of what I have told till now, the laser versus vitrectomy at 1 year, there was no difference in the visual acuity gain compared to laser alone. So in conclusion, anti-VEGF is the first line therapy in most cases. In mild edema and very good vision, as I showed in the protocol T result, there may not be a significant advantage of anti-VEGF over steroids. We need not wait for 6 months to switch between alternatives. It's not between just steroids and anti-VEGF. Even within anti-VEGF, you may have to look for switching before you wait for 3 to 6 months. Surgery is probably limited at this point of time to VMT and ERM, and definitely check for systemic status. Thank you very much.